All right, well, welcome back to Ultrasound Grand Rounds 2024. If you've been following along, we closed out 2023 a few weeks ago. We took a couple weeks off for the holidays, and now we are back, and I'm pretty excited. I've been thinking through this next term, semester, couple months, whatever you want to call it, and got a couple cool and interesting topics lined up and in the works that we're going to cover this month. This next couple months. Last fall, we talked a lot about cardio-resuscitative, thoracic, lungs, things like that. We're going to switch gears and talk a little bit more about other topics like abdomen, OB, soft tissue, MSK, things like that coming up in the next few months. So if that sounds interesting to you, definitely keep stay tuned and keep following us. For those of you who are on the YouTube channel, definitely hit that subscribe button, the like, and that notification button so you can know when these things come out. But today I'm pretty excited. We have a special guest with us to kick things off for the new year, for winter 2024. And this particular person comes highly recommended by a friend of mine, someone in the POCUS community, and someone who's also been on this forum giving lectures to us before. So today we have Sean Gibson from the University of Buffalo, recommended by our good friend Dan Mersch. And he is preparing a lecture, or he has prepared a lecture for us about shear-wave elastography. But before we get into that, just want to introduce Sean a little bit. Sean is a fourth-year medical student, University of Buffalo. He is looking to match into radiology, so best of luck to Sean in his upcoming endeavor here at the match. But he is pretty excited about some sports med topics, and this kind of draws back from some of his interest in sports, from the past and in the present. And so he wants to dig more into the use of ultrasound in evaluating and treating sports med injuries. So anyway, with that being said, I'm going to turn things over to Sean and let him take it away for his talk about shear-wave elastography. Sean, go ahead.
It's an honor to be here and chatting with you guys. Thank you, Dr. Tabbitt, for accepting this presentation. Thank you, Dr. Mersch, for recommending this presentation. I gave an abridged version of this presentation to Dr. Mersch and a few other residents and students at the end of my ultrasound rotation with Dr. Mersch. And he was excited enough to recommend it to Dr. Tabbitt, so I'm very thankful for that. I'm not sure how often you guys have medical students giving these presentations, so that's not to toot my own horn. That's kind of just to say I'm probably as terrified as you are. So I think I put together a pretty good talk, and I hope that from this, you guys can learn something about shear-wave elastography, and the bulk of the talk will be about the musculoskeletal applications of that. So let's get rolling. So the first thing is we'll talk about the theory of it, what it is, and why it's useful, and we'll dip a little bit into the history of that. I think it's important to kind of pay homage to the people who are responsible for the technology and the theory of the elastography. And off of that, we'll go into the physics. It's not really fair to show you guys a bunch of cool color ultrasound pictures and not talk about why those colors are appearing. It wouldn't make a whole lot of sense. So we'll talk about what those colors mean when we talk about the principles of reading shear-wave elastography. And then we will dig into some examples of common uses of elastography, as well as the MSK applications of it. So what is it? It's an adjunct to grayscale ultrasound, kind of like a color Doppler, but instead of looking at flow, you're actually looking at the stiffness or elasticity of tissue. And this is kind of like an ultrasound palpation device. Rather than just looking at grayscale and evaluating the tissue quality, you can put color to it and see how elastic or stiff a tissue is. Not only do you get qualitative data from a color map that's showing you the stiffness, but you can quantify it through an equation where you're using the shear wave speeds from the elastography and getting a shear modulus to tell you an exact number in kilopascals, the pressure, the hardness of tissue. And there are multiple techniques to accomplish that. Some, like shear wave, give you quantitative, and some, like stress elastography, which we'll touch on, do not. But it's worth mentioning that there are multiple techniques to accomplish this ultrasound palpation, if you will. So a little bit about the history of the technology. Its theory is that this is internal palpation, And the theory is that essentially, what if you could palpate solid organs that you wouldn't normally in a non-invasive fashion without kind of giving somebody an X-lap or really pushing on their abdomen? What if you had a device that could help you in evaluating the stiffness of tissue that was cheap, accessible, all the good stuff. Because palpation has been around since ancient times. People knew that palpation, telling you about the stiffness of tissue, telling you about the warmth, the color, all of that good stuff, will kind of correlate with the biological properties. But because it's only really great at big and superficial things, we haven't been able to dig deeper and look at solid organs in the abdomen with good accuracy. So first we'll talk about Jonathan Ophir, and he's credited with being the pioneer of this technology. He's a very interesting guy because he was doing his doctorate in the 1970s while also working for Philips Ultrasound. And part of his doctorate work was developing the digitization of ultrasound, meaning he's partially responsible for why we see images of ultrasound on screen. And he did that as part of his doctorate work. So he's a big deal in the ultrasound world. And then by the 1990s, he was describing the first form of elastography to come out, which was strain elastography. And through his work, it was 2003 that the first commercially available elastography equipment came out, and it was strain elastography. Then came along Catherine Nightingale and Armin Sarvazian. I'm not sure if it's Sarvazian or Sarvazian, but when I say Sarvazian, I sound like I'm on NPR, so we're going to go with that. Dr. Nightingale, her work was primarily in what's called the acoustic radiation force impulse. And from the acoustic radiation force impulse, traveling from an ultrasound transducer into soft tissue, she figured out that these shear waves were coming off of that force. So you can imagine that when Sarvazian saw that shear waves were coming off of that, he kind of took the baton, took the next step, and figured out that these shear waves had velocity, and the velocity of these shear waves could be tracked and plugged into an equation to give you the shear modulus. And it's that shear modulus that is your stiffness value in kilopascals. So why do we want to do this? As I mentioned before, you're going to be able to palpate structures that you wouldn't normally. And then as it relates to musculoskeletal injury, you'll be able to better define, characterize, and even predict injury based upon the numbers that you get on the tissue quality from the elastograms. It's not meant to replace grayscale ultrasound. It's kind of meant to be an extra tool in your toolbox and bolster your ability to diagnose and treat. You can imagine tracking somebody along a path of their treatment with ultrasounds in succession over and over and over again. And depending on the treatment you're giving them or the rehabilitation they're receiving, you can kind of guide what needs to happen next or monitor their potential return to activity. When I first learned about elastography, I immediately thought of Kevin Durant in what I believe was either the 2018 or 2019 NBA Finals. He is a basketball superstar. I'm pretty sure everybody here has at least heard of him. And he famously tore his Achilles in the NBA Finals. But many people might not know that a few rounds previous in that same NBA playoffs, he was jogging up the court and had a calf strain, which at that time, many people thought he tore his Achilles, but it came out after the fact that he had just strained his calf. He took a couple weeks off, and in his first game back, he actually snapped his Achilles tendon. And many people will say that, you know, those two injuries were unrelated, the calf strain and the Achilles tear. But I'd like to argue that if this technology was potentially used, you could assess the tissue quality a whole lot better and decide whether or not he would have been able to play that day. So like I mentioned, it's not really fair to show you guys a bunch of cool color pictures of the ultrasound without talking about how we get them. So we'll dive a little bit into the physics of the technology. Hopefully I provided enough depth of the physics to tell you about it, but not too much to bore you. But please jump in if you have any questions, because parts of this can get a little bit confusing, but I hopefully distilled it a little bit to make it digestible. So I'll first describe in words the physics of the shear-wave elastography here. And on the next slide, you'll have an image of kind of what this all means, and I'll go through it again. I did this intentionally, kind of give you a double hit about the physics to make it more digestible, absorbable, all that good stuff. So first off, you get shear waves that are moving perpendicular to your ultrasound beam. So that acoustic radiation force impulse that Nightingale and Sarvazian worked on is going to come off perpendicular. So your ultrasound beam is going to go down into the tissue And the shear waves, you can imagine, are actually making a right turn and going 90 degrees to that beam. And what that does is it's going to create a shear force on the tissue that it's moving through. Those shear waves are going to create a shear force on the tissue they move through. They're going to displace the tissue. And from those displacements, which are different in different types of soft tissue, so tendon will react differently to the shear wave, fascia will react differently to the shear wave, muscle will react differently to the shear wave. From the amount of displacement of those tissues from the shear wave, you can calculate the shear wave velocity. And through Sarvazian's work, the shear wave velocity can be correlated to the shear modulus through an equation, which we'll get to on the next couple of slides. And it's that shear modulus that is the correlate to the tissue's elasticity. And then finally, the shear modulus can be mapped in color and give you a color ultrasound image to describe the stiffness of any given tissue. So here again is a pictorial of what I just described. So in step one, you have a linear ultrasound array, and perpendicular to the acoustic radiation force that's coming off of the ultrasound transducer, you get these shear waves running perpendicular to that ultrasound beam. And it's these shear waves that displace soft tissue through a shear force. And through that displacement, you get a shear wave velocity, which can be tracked and mapped by plugging it into the equation for the shear modulus, which is down here, where G is equal to the tissue density times the square of the shear speed. So it's a little bit confusing, but what's interesting about it is that the displacements that the shear wave creates on the soft tissue can actually be tracked down to the size of microns. So it's very impressive, the shear-wave elastography equipment and how exact it can be. But you get an equation, you get a number for the shear modulus, and you can understand a little bit more about the stiffness of tissue. It's worth mentioning also that these shear waves travel 1,000 times slower than a conventional ultrasound wave, but they attenuate a whole lot faster too, which is going to make tracking them both easy and difficult to kind of catch and capture because of that fast attenuation. I show here the acoustic radiation force impulse because in my research and talking about this topic, I kept running into the acoustic radiation force, the acoustic radiation force, the acoustic radiation force. Nobody really gives you a good answer about what the acoustic radiation force is. It's important for this talk to know that the acoustic radiation force impulse creates a shear wave that's perpendicular to the acoustic radiation force. But in my research, I did find that any sort of radiation, as it moves through a medium, as it encounters an obstacle, it's going to impart a force on that. And sound waves are no different. So it's essentially saying that sound waves move through a medium and they impart a force on the medium they're moving through. In this case, you also get the shear waves that come off of it and give you more information about the shear force they're imparting through that medium, and you can find out about the stiffness through that. So Sarvazian described these shear waves as an internal finger for palpation, and I did not like that at all, as I'm sure many of you don't either. So we're going to call it an imaging probe, these shear waves. Also, it's very specific. You get a region of interest, which is kind of like that exact area you're looking at. The acoustic radiation force impulse is like very accurate at what it's looking at, and you can glean a small region of interest from the shear wave that's coming off of that acoustic radiation force. So I mentioned Young's modulus here as well. And the only reason I bring this into it is because this is the traditional measure of a solid stiffness, is what's known as Young's modulus. And because of that, many articles in the literature will refer to Young's modulus as opposed to the shear modulus. So in some papers, you'll see E, in some papers, you'll see G. Both are reported in kilopascals, both report the tissue stiffness. But I did want to show you kind of how they were interrelated. So E, the Young's modulus, is equal to 2 times the shear modulus times 1 plus Poisson's ratio, which is little v or nu. Poisson's ratio is the ratio of lateral strain to longitudinal strain on tissue. But the good news is when you're doing elastography, Poisson's ratio is kind of pointless because you make a lot of assumptions in the physics of elastography to produce images that look nice. One of those assumptions is that biological tissues, because they hold so much water, they're essentially incompressible. And when tissues are incompressible, it makes the Poisson's ratio 0.5. Plugging it back into this equation, you find that the Young's modulus is just equal to 3 times the shear modulus, or the shear modulus is just 1/3 the Young's modulus. But As I mentioned, both are reported in the literature to give you an idea of tissue stiffness. Other elastography techniques, I'll touch mostly on stress or compression elastography. And that's because this is what Jonathan Ophir created when he kind of pioneered the technology of elastography. And what this does is, rather than using a shear wave to generate a shear force against tissue, you, the operator, are creating that force by just pressing the transducer onto tissue. And from that, you get an idea of the strain you're putting on tissue. So you can kind of take a before and after B mode image, and from that you can get a color map elastogram to demonstrate the stiffness of the tissue you're looking at. You can see here the pictorial, like pre and post compression, and the stress you're putting on the tissue. The biggest issue with this is that the way that I press on somebody's forearm, for example, might be different than the way that Dr. Mersch presses on somebody's forearm. You can't really exactly calibrate how much stress to impart on your patient with the ultrasound transducer. And because of that, you can't get quantitative data about the stiffness of tissue, but you do get that color elastogram from the before and after image. And for that, you still get qualitative information about tissue stiffness. But shear wave is kind of emerging more because of its objectivity. Transient elastography is another form of acoustic radiation force impulse imaging. However, it is designed to be kind of more like a snapshot for dynamic elastography imaging. And it has much, much more limited depth. And because it's kind of regional and dynamic, you don't get an absolute measure, specific acoustic radiation force impulse beam going into the tissue to provide a shear wave at a specific point to give you an absolute measure of the shear modulus. But you do get a good idea. And it is used a lot of the time in liver fibrosis to kind of track how fibrotic somebody's liver is or is becoming. So I mentioned the benefits of shear wave here after the other techniques to kind of buff it up a little bit, because it is reproducible. You're dealing with the shear wave, and the shear wave is the shear wave. It's not going to change. It'll change because it's encountering different types of tissue at different depths. But like I said, the shear wave is the shear wave. It's not changing coming out of the transducer. Because of that, you can quantify the shear wave speed, plug it into the equation for the shear modulus, and get an idea of the tissue stiffness. And where stress elastography gives you a relative comparison of tissue before and after compression, this is absolute data. This is like the tendon has a shear wave speed of 5 meters per second, or the muscle has a shear wave speed of 2 meters per second. And you get exact numbers to put to different types of tissue. So I'm going to take a sip of water quick. If anyone has any questions, I'm happy to take them at any time. I can't see what's going on in the chat, so I'll just forge on and I'll allow anyone to interrupt me if they would like to. The other applications of shear wave elastography are essentially why elastography was created. Mainly liver tissue and breast tissue is evaluated with elastography. The point of this talk is more musculoskeletal related. So we will get to that, but I do want to mention these because this is kind of like why elastography was made. So it's worth mentioning these points. And before I show you your first color maps of elastography, I want to go over partially now the rules of the game to elastography. So when tissue is stiff, shear waves are going to move faster through that tissue. And the convention for most papers in the literature is that you use red to define fast and stiff, and you use blue to define low velocity or soft tissue. Green and yellow is intermediate, but really once you start to see some light blues and greens, that's when you start to worry about tissue stiffness. But the point is that when you see these color maps, these elastograms, just remember that when you're seeing yellows and reds, you're looking at something that is stiffer because shear waves are moving faster through it. And once you plug that shear wave velocity into the equation for the shear modulus, you're going to get a higher shear modulus, a higher value of kilopascals to define that stiffness. And when a tissue is soft, I will repeat, when a tissue is soft, you're going to get low velocity shear waves that move through it. And that tissue will appear blue underneath the elastogram. So liver disease is one of the huge applications of this. Fibrosis is caused by a ton of things, drug-induced liver injury, alcoholic cirrhosis, hepatitis, things of that nature. And once you take a biopsy of somebody's liver, you can grade the fibrosis within that tissue, that specimen. And you can go from F0, where there's zero evidence of fibrosis within the liver tissue, all the way up to F4, where you're dealing with full-on cirrhosis of the liver. And there's F1 through F3 in between there, but just wanted to mention the spectrum. And this is really cool because elastography is actually very sensitive and specific for defining on ultrasound how fibrotic somebody's liver is. If you use a shear wave speed of 1.55 meters per second to be your cutoff for F3 or severe fibrosis of the liver, you have greater than 85% sensitivity and specificity for that diagnosis of severe fibrosis. And if you use a shear wave speed of 1.8 meters per second to define F4 or full-on cirrhosis, you also have a greater than 85% sensitivity and specificity for that diagnosis. The only downside of shear wave elastography for liver imaging and elastography at large is that through ultrasound, we can't really define benign or malignant focal lesions by looking at the stiffness of those lesions. So here's an image, I believe 4 different patients, all with hepatitis, and going from top left to top right to bottom left to bottom right, you're increasing the pressure or the stiffness of that tissue from 7.1 to 7.8 to 9.5 to 24.5 kilopascal. So from that, you can glean that all 4 of these images, all these different patients, all have a different level of fibrosis from their hepatitis. So on the bottom right, you're probably dealing with somebody who has full-on cirrhosis or at least severe fibrosis of the liver. You can see all the yellows and reds within that elastogram, which correlate to that tissue being a whole lot stiffer than if you look at the top left where you see these deep blues. Potentially this person has like F1 disease, but it's a whole lot softer than what you're seeing in the bottom right, which is probably somebody dealing with full-on cirrhosis. Breast masses are huge in elastography. On the left, you're looking at a fibroadenoma, and on the right, you're looking at invasive ductal carcinoma. The cool thing about elastography in breast masses is that for breast masses, as well as for thyroid masses, actually, the tissue stiffness correlates directly with whether or not that tumor is malignant or benign. So benign things in breast and thyroid cancers are going to be soft. They're going to be deep blue. They're going to be low velocity shear speed. And things that are stiffer, that appear more green, yellow, red are generally malignant or have malignant potential. So you can see here the fibroadenoma is deep blue. It's soft. It's most likely benign. And then on the right, you're seeing a lot more reds, yellows, greens to show you something that's stiffer, something that you're a little bit more worried about. And we have BI-RADS classification for breast masses, which have a sensitivity and specificity down here of 97.2 and 61.1 for their diagnostic accuracy. Once you add on shear wave elastography to help you in your diagnosis for breast masses, you improve your sensitivity to 98.6 and you improve your sensitivity all the way up to 78.5. One of the things that's mentioned in the literature in this paper by Kui is that somebody with like 3 BI-RADS, and then you slap the shear wave elastography onto their mass and you see something that looks like this on the right where it's stiffer, it's harder, that might warrant increasing their BI-RADS classification and potentially sending them for biopsy. So it's very useful in helping determine people who are on the border of 2 different BI-RADS classifications as well. So finally, we'll get into the bulk of the talk, which is the MSK applications of the shear wave elastography technology. And before I do that, I want to pay my respects to Dr. Kenley. He's a radiologist at the University of Wisconsin who does a lot of tremendous work in musculoskeletal ultrasound. I know Dr. Kenley personally. He's kind of a mentor to me from afar. He was the first radiologist I ever shadowed actually as a undergraduate student. Back when I was at Canisius College, I flew out to Madison, Wisconsin to shadow him. And I later found out that he's actually a family friend of my uncle. So it all worked out, but we met each other and he's been providing me tons of advice on radiology. So I want to pay my respects to him. And as I mentioned earlier, I gave an abridged version of this talk to Dr. Mersch, some other students and residents back at Buffalo General Hospital a couple months ago. And the reason why I gave this talk is because of him. I actually searched his name into radiographics to look at some of the topics that he was working on. One of them was elastography, which is something that I didn't think was initially interesting, but then when I kind of related it to why I wanted to go into medicine, which is to improve the treatment, management of sports injuries, it just made too much sense. And the more I talk about it, the more I research it, the cooler I think it is. So I just want to say thanks again to Dr. Lee. So musculoskeletal pathology is generally going to be slow shear wave speeds and soft tissues. I gave this talk to a couple friends and they said that this slide was perhaps the most confusing of anything I gave. I think that's really just because of the words. So I'll go very slow and go through everything on the slide because it is important in determining how you look at these elastograms and glean information from them. So generally speaking, in musculoskeletal pathology, things that are pathologic are going to appear blue because the shear wave speed through pathologic MSK tissue is going to be slow, and therefore its stiffness is going to be not stiff. It's going to be elastic. It's going to be soft. Shear waves will move faster through healthy tissue, so they'll be higher on this color scale versus tendinopathy, which will be lower on this color scale. Shear waves will move faster through contracted tissue. If you picture putting an ultrasound transducer on your thigh and then isometrically contracting your quadriceps muscles, you would actually see a difference in the shear wave speed pre and post contraction of that muscle versus if it were relaxed. And then finally, shear waves will move faster when they're aligned parallel to tissue fibers versus when they're transverse to tissue fibers. So think about putting a linear transducer onto an Achilles tendon, the length of the Achilles tendon, so that the shear waves, if you think about the ultrasound beams coming down, the shear waves would be in length with the Achilles tendon. Those waves will move faster through that tendon than if the linear transducer and the shear waves coming out of it were moving perpendicularly to the short axis of the tendon. So as a result of that, again, I'll mention this part stays the same from when you're looking at the breast and the liver stuff that I talked about, but elastograms will be red when tissue is stiff, and that's because the velocity of the shear waves are going to move more quickly through stiff tissue, and then blue when that tissue is soft, because shear waves are going to move more slowly through soft tissue. Green, yellow, and even light blue is more intermediate stiffness. I'll mention at baseline, tendons are going to be light blues, greens, maybe some yellows to define healthy tendon. At baseline, healthy muscle is blue or light blue, but that can change. If you contract a muscle, it'll appear stiffer, and the color of the elastogram might change as a result of that. I have an example to show that. So we'll get into some of the examples now. First up, I have an Achilles tendon. On the left, you have a healthy patient, and on the right, you have a diseased Achilles tendon. And this is an Achilles tendon rupture, actually. Before you even look at the color elastogram, if you look at the bottom left and bottom right images, you see the organization of the Achilles tendon fibers here looks so nice. And then on the right, you have all of this disorganization, and you actually have this signal void because fluid has started to fill the space of that rupture. Once you put the color elastogram over that, you see some light blues, some greens, which define kind of a healthy tendon here. And then on the right, look how deep this blue gets. If you look at the numbers on the side, in some of these images, you'll be able to tell the pressures, the stiffness of the tissue, but in others you won't. But I'll point it out here. The max stiffness of this tendon is 258 kilopascals. And on the right, the max stiffness of this tendon is 92 kilopascals. So massive difference there. You have that quantifiable data to say that this is stiffer than this. And in this case, it's because this person ruptured their Achilles. So there isn't a ton of stiffness, a ton of tension in that tendon. Here's another example of tendon. In this case, you have a patient this is the same patient, as a matter of fact. On the left, this is pre-treatment for their lateral epicondylosis of the extensor tendon. And then on the right, you have post-treatment, post-non-operative treatment for this lateral epicondylosis. And as I mentioned, healthy tendon is going to be light blues, greens, and yellows. And you see that on the right, post-treatment. Pre-treatment, you have all of these deep blues to suggest tendinopathy of that extensor tendon. When we talk about muscle, I mentioned earlier at baseline, it's blue. And I apologize, these images all come from different papers. So what's healthy, what's diseased is kind of confusing. So I'll point it out again. On the left, the top left, you have a healthy gastrocnemius and soleus muscle. And on the right, the top right, you have an elastogram of that same patient, of that healthy tissue. On the bottom left and bottom right, you have a tennis leg injury, which is essentially a calf strain, forced dorsiflexion of the foot to kind of really stretch out the border of the gastrocnemius and the soleus muscles. Looking at the grayscale, you see much more organization of the muscle tissue, and you see much more disorganization of the muscle tissue on the bottom left. Once you look at the elastograms of this, on the top right, I said muscle was blue. Here it's green and yellow, and that's because they actually put this foot in a little bit of dorsiflexion to stretch out the gastroc and the soleus, and as a result, the muscle actually became much more green and yellow. On the bottom right, you have the tennis leg injury, the diseased muscle, and it's a ton of deep blue. A lot of inflammation, swelling can create that. Something very cool about these images actually is that if you look at the fascia junction between these two muscle bellies, on the top right, you see all of these yellows and reds in between the gastroc and the soleus. And then even here, you have this deep blue image of the diseased muscle. But when you look at the border of the muscles, you see some light blue, and that's because the fascia is going to be one of your stiffer tissues at baseline. So you see that stiffness within the muscle to suggest that fascia is there. This is perhaps my favorite image in the whole talk because the theory behind it is really, really cool. So you have somebody who has a trigger point in their trapezius muscle, and we all have them. We hold so much tension in our shoulders. In the top left and in the top right, you have somebody who's sitting upright. On the bottom left and the bottom right, you have somebody who's now lying prone. And you can imagine when you're sitting upright, you're holding a lot of tension in your trapezius muscles. And then when you're lying prone, you kind of relieve that tension. So going from top left to bottom left, when a patient with a myofascial trigger point in their trapezius muscle, as denoted by this extremely red, angry, stiff muscle in the elastogram, when they go prone and they relax that, you see immediate relaxation of that to suggest that the muscle is no longer as contracted as it was. And then when you dry needle that myofascial trigger point as well, when you move from left to right and you try to relieve that tension, you also see immediate relief in the muscle. You go from red, angry, stiff to softer blues, greens to suggest relief of that myofascial trigger point. And that happens both when you're dry needled and prone and when you're dry needled in upright position. Rheumatologic disease is a huge burden on the medical community as well in the musculoskeletal field. So you can actually track the worsening of rheumatologic disease with elastography. And we know that the hallmark of this disease is kind of destruction, inflammation of the synovium. So here you actually see a healthy extensor pollicis brevis tendon in the first extensor compartment. But if you look at the tendon sheath, this should not look like this on grayscale. So on grayscale, you already know something's up when you're looking at this. It's distended. You can kind of appreciate that there's some heterogeneity in there. And on the elastogram, you see that because it's pathologic, that tissue is blue. The shear waves are going to move slower through it and depict it as soft on the elastogram. But you can picture having somebody with rheumatoid arthritis in your clinic over a length of time and tracking their disease to give you a better idea of what they're going through. Now, nerves are an exception to the typical MSK shear-wave elastography principles, and that's because once you're dealing with something like nerve swelling and carpal tunnel syndrome, for example, the pathologic tendon is actually going to get stiffer in this case. Sorry, not tendon. The pathologic nerve is going to get stiffer in this case. On the top, you have what's a healthy median nerve. And at baseline, it's this deep blue. And then once it becomes pathologic, looking at the grayscale from top to bottom, look how much more distended and angry this nerve kind of looks. And then when you compare the elastography images of the healthy median nerve to the diseased median nerve, you find that there is a lot more stiffness in here. And it actually, you can put numbers to it because it's shear wave. And you see that on the top, you have 42 kilopascals versus 89 kilopascals. So this is twice as stiff. Unlike breast and thyroid masses, the MSK system doesn't really help you out in terms of telling you what's malignant and benign based upon their stiffness. So on the top, you have an enchondroma, which is a benign cartilage-based tumor of the musculoskeletal system. And on the bottom, you have an osteosarcoma. So benign, malignant, yet up top, you have a ton more stiffness via the elastogram because of the reds and the yellows and the greens. And on the bottom, you have a ton more softness, which is not what you would expect in a malignant versus benign tumor. But just wanted to point this out, that it's unlike breast and thyroid in helping you determine whether or not something's benign or malignant. There's a lot of work into this right now because there is a ton of benefit to know through ultrasound if something is benign or malignant rather than giving somebody a biopsy potentially. But as of now, there is no correlation between benign and malignant tumors by looking at them through shear-wave elastography. So I include this picture because if anyone's seen the show, this is Tim Robinson from I Think You Should Leave. And in this sketch, he is pulling on a door where you are supposed to push. He argues with the person yelling at him that the door actually does both. So I thought that was funny because shear-wave elastography, unfortunately, you don't have this direct correlation all the time between disease and healthy by looking at stiffness. It does both. Sometimes stiff things will be healthy or unhealthy. And that's the case, as I just showed you, with the musculoskeletal tumors. So that's one of the pitfalls of elastography, is that you kind of need to always kind of have your brain turned on and correlate clinically. I'm sorry, I had to say that as an aspiring radiologist. You have to kind of correlate clinically the tissue to its stiffness. So other pitfalls, you need a lot more standardization, the way that people press on tissue, the way that people have patient position, the way that you're holding the probe, the activity that the patient is in. As you saw earlier, muscle, when it's stretched versus unstretched, will look entirely different. And another thing is you need special ultrasound software. You need a special ultrasound machine to provide you with the shear-wave elastography capabilities. Most of the time when you're in the ED and you find the point of care ultrasound, it's not going to have this capability. And then it's worth mentioning the probe pressure that you're placing on a patient can also impact the shear waves. If you're putting too much pressure, it can kind of communicate and mess up with the shear waves and make a more noisy calculation for the machine as it's trying to determine the stiffness of tissue. I mentioned you need special ultrasound software. So Dr. Tabbitt can check me on this. These numbers are brought to you by google.com. These are a handful of machines that have shear wave capabilities, the Philips Epic, the GE Logic, both with Qs instead of Cs. I thought that was interesting. And then the Siemens Accuzon S3000, which is used a ton in the literature to provide those images that you saw. So for the most part, you're looking at stuff that's going to be in the range of $50,000 or more in order to purchase this for your hospital. So that's a downside. But I just wanted to summarize the whole talk by mentioning again that this is a reasonable adjunct to grayscale for characterizing injuries. And through this technology, you can evaluate tissue healing or worsening longitudinally in clinic or, in the ED, depending on the injury. And then shear-wave is unique because not only is it giving you qualitative information about the tissue stiffness like stress did, where you're looking pre and post compression to determine how stiff a tissue is, you get a number to put to things like tendon and muscle and ligament. And from those baseline quantitative numbers, you can determine whether something's diseased based upon how those numbers fluctuate. So that's a really cool aspect of this. So I have my references for you here. And then at the end, I have a picture of my friends and I after we won our first trivia, bar trivia a couple Wednesday nights ago. It's not about winning and losing. It's about the friends that you win with along the way. So thank you for listening to my talk. I'll take any questions if anybody has any.